Good morning, Chairman, Co-Chairman, and dear colleagues. Today I would like to present my research entitled "Is with Attention Related to the Poor Shoulder Functional Outcome in Neonatal Brachial Plexus Palsy, Narakas I, II, and III." My name is Chaloemkiat Suwannathen. My advisor is อาจารย์ขันชัย มะลังไพศพ เลิศศิลป์ General Hospital, Bangkok, Thailand. From the background, the neonatal brachial plexus palsy or NBPP is C5 to T1, the neurologic injury in the newborn. The incidence is 1 children per 1,000 births. Some infants with the partial recovery have the permanent, the progressive limitation in the motion and strength of the shoulder. This problem makes us want to know how to divide this group. Our primary objective is to study the shoulder functional outcomes in NBPP at 2 years of age, and to study the factor that related with poor shoulder functional outcome in the secondary objective. We hypothesized that one of these factors, the failure recovery of the elbow flexion, the wrist extension at 6 months, or the Narakas grading at the 6 months, make poor shoulder functional outcome. The inclusion criteria are the newborns with the Narakas I, II, and III without the shoulder deformity. And the exclusion criteria are the newborns that need the intervention to treatment about the shoulder internal contracture or have the other neurologic problem. We study as the retrospective cohort and child review and follow up the patient every 3 months until the 2 years of age with the conservatively by shoulder exercise programs. All NBPP patients and their parents in the Lersin Hospital will receive the training shoulder exercise course for the protected the complication such as the joint contracture. And then the patient will examine at the active movement scale score composing of the shoulder forward flexion, shoulder lateral abduction, and shoulder external rotation, or perform with the modified Maulet score in the hand-to-neck position if able to command. And then interpretation at the 2 years of age. The good outcome is defined by all of the active movement scale score, the shoulder forward flexion, and shoulder lateral abduction at least 6, and modified Maulet in the hand-to-neck position at least 4. If not, it defines poor outcome. The data was analyzed at SPSS program. The result, there are 38 patients, and poor outcome was found at the 24 patients, which is around 63%. All these factors were analyzed with logistic regression, and the failure recovery of elbow flexion and wrist extension at the 6 months and Narakas grading at 6 months were found to be significant factor for poor outcome. And then calculated with the multiple logistic regression. Finally, failure recovery, elbow flexion, and wrist extension at 6 months were statistically significant, but it quite wide range of 95% confidential interval. In discussion, 63% are poor shoulder functional outcomes correlated with the Pondak et al. That report the shoulder function trend to have the residual neural deficit. Some infants with the partial recovery have the permanent progressive limitation in motion and the strength of the shoulder, and warrant the surgical exploration and nerve reconstruction. Correlated with the Ford et al. In the 2009 that report the permanent neurologic deficit is around 40%. We found the related factor are the failure to recovery at the 6 months of age in the elbow flexion and wrist extension. Correlated with the Water et al. Address the late recovery of bicep function is related to permanent deficit, especially shoulder function. So, from our research, found in a new factor, the failure recovery of the wrist extension at the 6 months, that currently no literature regarding this factor. The clinical relevance are to select the patient for early nerve surgery instead undergo the secondary reconstruction and late risk for the irreversible loss of the motor end plate. In conclusion, the shoulder functional outcomes after the consecutively in the Narakas II and III tend to be poor. Even good passive motor exercise. Related factors are the failure recovery at 6 months of age in the elbow flexion and wrist extension. The retrospective and too small sample size is our limitation. Thank you. ขอบคุณครับ
Thank you for presentation. Does anyone have a question?
I have one question. How to evaluate the head to neck
Pardon?
in young child? Hand to neck.
In a hand to neck position?
Yes.
Actually, the accuracy physical examination is one of the most difficult to examine this patient group. In this position, we use the toy to trick the patient to pass the toy at the posterior neck of the patient and let them to grab it. Or sometimes we use a stick at the posterior neck and observe there to remove it.
Thank you.
For the next paper, clinical and radiologic outcomes of basal thumb joint reconstruction without trapeziectomy in basal thumb. Dr. Pongpan Kaujari, please.
Good morning, Chairman, Co-Chairman, and my dear colleagues. Today, I would like to present my research. The title is Clinical and Radiological Outcome of Basal Thumb Joint Reconstruction without trapeziectomy in basal thumb arthritis. Basal joint osteoarthritis of the thumb is common degenerative problems, which moderate to severe degree of disease require surgical treatment. However, several surgical treatment options exist. In 1949, Dr. Gervis Murray proposed simple trapeziectomy, which removed total entire trapezium, with satisfactory result in pain relief, but some concern that may result in shortening, subluxation, instability of thumb, and grip weakness. So various modifications have been proposed to overcome these potential problems. According to Dr. Gervis Murray in 1949, report simple trapeziectomy with satisfactory result, but 15 from 39 patients complained about grip weakness. So according to Dr. Brandon, published in Journal of Hand Surgery 2009, patients underwent simple trapeziectomy may be at risk for carpal instability. And green operative surgery also suggests that complete excision of trapezium can lead to axial collapse of metacarpal and potentially lead to painful abutment of metacarpal and distal scaphoid. So nowadays we try to minimize the post-op complications after total trapeziectomy with ligament reconstruction and tendon interposition. So this leads to our research question. Does basal thumb joint reconstruction without trapeziectomy improve clinical and radiological outcome in patients with basal thumb arthritis? So we hypothesize that basal thumb joint reconstruction without trapeziectomy can reduce basal thumb arthritis symptoms and disability. Primary objective was clinical outcome, and secondary objective was radiological outcome and range of motion. So this study design was prospective pilot study. We include Patients who diagnosed with basal thumb arthritis underwent basal thumb joint reconstruction without trapeziectomy in Lursin Hospital between August 2016 to December 2017, and with moderate to severe degree, classified by Eaton classification, stage 2, 3, or 4, and age more than 18. We exclude the patient who have soft tissue infection around basal thumb, and the patient who experienced surgery at basal thumb joint, and patient with post-traumatic arthritis at basal thumb, and patient who follow up less than 12 months. So for demographic data, we collect the gender, age, affected site, and severity of disease. We assess primary outcome with quick dash questionnaire and visual analog pain scale, strength with hand grip, and pin strain meters. And secondary outcome consists of subsidence between base of first metacarpal bone and trapezium, and radial translation of base of first metacarpal bone over trapezium, and also the range of motion of thumbs. So for statistics, for the demographic data, we present with frequency and mean with standard deviation. And we use paired t-test for normal distribution data, and Wilcoxon-Son rank test for non-normal distribution data. And we also use descriptive statistics for questionnaire, clinical measurement, and radiographic measurement. Okay. And for the results, we collect total 10 patients, 3 males, 7 females, mostly Eaton stage T. Mean age was 55 with standard deviation at 11 years. 6 right side and 4 left side. We observed a significant improvement in disability from 37 to 19 score in quick dash score, and pain score from 3.7 to 1.7, and also tripod pin strength from 3.4 kilo to 3.7 kilo, and key pin strength from 3.1 to 3.4 kilo. And also improvement in radial translation of basal thumb joint also observed from 45 to 34%. About grip weakness and thumb shortening, there's no difference in pre-op and post-op in grip weakness. So we conclude that ligament reconstruction with tendon interposition without trapeziectomy result in excellent relief of pain and disability improvement, and can also preserve thumb length, grip strength, and range of motion compared between pre-operative and post-operative, at least in short-term follow-up at 1 year. A limitation in this study is, the first one is small numbers, and the second is a short follow-up time, only 1 year. Thank you.
Thank you for presentation. And this idea support the idea of Professor Omokawa about the trapezotomy. Do you have a question? Okay, please.
Thank you for your presentation. You did ligament reconstruction and interposition without trapeziectomy.
Yes.
Is that right?
Yes.
And how do you interpose the tendon? Please tell us the detail of the technique.
For the detail of the after we use the 40% of the ECIL tendon, and we split it, and then a reconstruction between the CMC joint. Then we create the tendon ball, and we insert it between the joint.
Okay, tendon ball interposition is needed because there is one surgeon in Japan, Dr. Mizuseki from Hiroshima, and he do a similar technique like you, but he just do the eternal literal ligament reconstruction only, not the interposition. I think that's enough to stabilize the joint. Yeah, and so this is my opinion. Thank you.
Thank you.
Thank you.
Okay, please. Okay.
Okay, can you explain why the pain is improved in the Eaton stage 3 or 4 because the cartilage already gone and you just do the ligament reconstructions?
Thank you for your interesting question. In Eaton, for the moderate to severe severity of basal thumb joint arthritis, there are two main components that cause the pain. The first one is instability, and the second one is like an inflammatory process between joints. For the first one, instability, we correct it with ligament reconstruction. And for the second one, for the inflammatory process, we correct it with like a tendon interposition between the joint, and we remove the osteophyte, but we didn't remove any cartilage or bone.
So in your case, there has the space in the joint without remove the bone, right?
Yes, because there may be some instability. There are two components. So there's some space that we can insert the tendon bone into that.
Okay, thank you.
Okay, thank you. That's okay. Please. Please, another question, please. Okay.
Excuse me, what is the main factor that you perform the operation for the patients? Because I see the visual score is not so high. It's about 3 or 4. Please.
For the main factor that we decide to do in surgery treatment, the pain is also one of the factors. The other factor may be the disability of the patient. That's the patient complain that cannot do daily activity or their occupation.
They complain about the activity more than pain, all right?
Yes.
Okay, thank you.
Okay, thank you so much.
And the last paper, comparative mechanical property of conventional and locking cushioner Y in chicken humerus. Dr. Vilanon Chanyawongsak, please.
So good morning, Chairman, Co-Chairman, and all ladies and gentlemen, and all of my respect, hand and microsurgeon, and every orthopedic surgeon. My name is Vilanon Chanyawongsak from Pramagutgao Hospital, Bangkok, Thailand. Today it's my pleasure to present comparative mechanical properties of conventional and locking K-wire fixation in proximal phalanx fracture. This is an experimental study in the chicken humerus. So we have no conflicts to disclose in our presentation and research. As we know that there are many kinds of the fixation for the proximal phalanx fracture, such as the K-wire in both claws and intermediate fixation, leg screws, head and screws, and external fixation. However, there are many complications for this kind of the fixation, such as the malunion, PAP joint, friction contracture, and the joint stiffness. So we can prevent these complications with a stable fixation and every range of motion of the patient. Nowadays, cross or conventional K-wire is one of the most famous techniques for the fixation in the hand fracture, with no technical demand at low cost, but it less reliability about its stability and need postoperative immobilization, so the patient can't achieve the every range of motion. So we developed the locking K-wire by connecting both ends of the K-wire together to increase the construct stability. It's not only no technical demand at low cost, but it also increases the stability and allow our patient to have an early range of motion, as we shown in the video. So nowadays, there aren't any biomechanical or clinical comparison between conventional and locking K-wire fixation. There's only some literature review about the comparison of conventional K-wire with the other techniques in biomechanical aspect. So our research is first research to test and compare the biomechanical properties between locking and conventional K-wire fixation. After we correct about the 40 fresh chicken humerus, we divide them into groups with 20 bones for conventional K-wire and the next 20 bones for locking K-wire. And then we subdivide 10 bones for tension and the other 10 for 4-point bending. After that, 40 fresh chicken humerus were did with diaphyseal osteotomy in the transverse plane with the oscillating saw. And then we did the K-wire fixation with the conventional and locking K-wire. That all operation be done by the same surgeon team. On the left-hand side show us about the cross conventional K-wire, and the next one is the locking K-wire. After that, we did the biomechanical test with the low-cell universal testing machine called Shimazu in the tension and 4-point bending. Let me introduce you about the locking K-wire. The first one, we did the mid-diaphyseal osteotomy, and then we did the K-wire fixation with number 1.25 millimeters from the osteotomy site. And then we bend both ends of the K-wire at 90 degrees and locking both ends of the K-wire to increase the construct stability. So we call the locking K-wires, as you see in the picture. For our result, locking K-wire gives us significantly higher stability in tension with every modes, such as maximum force, maximum displacement, and the maximum strain. And also in the 4-point bending, locking K-wire gives us significantly higher rigidity in every aspect. Let me discuss about our research. Our mechanical study shown that locking K-wire shown higher stability significantly than conventional K-wire. For the tension is 2.78 times, and 4-point bending is 1.8 times. So if we notice for cross K-wire in the 4-point bending mode, our study shown that locking cross K-wire in our study is comparable to the other study, such as the maximum force, maximum displacement, and elasticity. So our study is quite reliable. And also with 4-point bending in the chicken humerus, locking K-wire gives us higher stability more than the other techniques of the fixation, especially elasticity. So however, our study has some limitations because we conducted in non-human specimen. We didn't perform the test in cyclic load and torsional force. And the last one is about the prominent implant of the locking cross K-wire that interfere hand function. So every patient must be emphasized on the local pin care and protection. For conclusion, the locking cross K-wire group has significantly better biomechanical stabilization over conventional cross K-wire fixation method. We want to acknowledge Mahawacharankon Foundation, Pramukutgao Hospital, and Dent Material Department, Faculty of Dentistry, Chulalongkorn University. In the future, for further study, we will try to perform an evaluation in the real benefits of locking K-wire in both radiographic and functional outcomes. Here is our reference. And thank you for your attention.